This is the worst wisdom tooth case I've ever seen. What started as a routine evaluation for wisdom tooth pain became a devastating diagnosis for a 17-year-old. The only clue was a tiny radiographic finding that is so easy to miss. I'm Dr. Tom Bolten, board-certified oral and maxillofacial surgeon, and this is the open reduction. This case started in an unusual way. A friend reached out to me about a colleague's son who had persistent jaw pain. He had already seen several doctors and specialists, but no one had been able to find the cause. I promptly had the patient come in for an evaluation. The patient and his parents were very organized and came with detailed reports from CT scans, MRIs, physician visits, and neurology consults. This patient was experiencing dull, throbbing pain of the left mandible and decreased sensation of his lip and chin. The radiology reports from his CT scan and MRI showed no abnormal findings. I obtained a cone beam CT in my office. At first, everything looked normal, but something about this case did not sit right. There was concern the wisdom teeth were the cause of his pain. He had pain on palpation of all of his wisdom teeth and deep probing depths behind the second molars, so I agreed it was prudent to remove the wisdom teeth. I wasn't convinced the wisdom teeth were the source of his concerns, but in an unusual case like this, it's good to rule out potential pain sources. He underwent extraction of his third molars under IV sedation, and there was nothing unusual about his surgery. I saw him back 1 week later and everything was healing well. There was no sign of pathology and the sites were healing appropriately. However, he still had pain on the left and decreased sensation. I was happy things were healing well, but his problem was not solved, so further investigation was necessary. I decided to speak with the neurologist who originally saw him, and I scheduled him for a 1-week follow-up visit. Now we're 2 weeks out from when I originally saw him, and when he came back, this is what was there. There is a large exophytic growth at the number 17 extraction socket. This lesion is not painful, but the patient can no longer close his teeth together. This is one of two things: a reactionary lesion like an epulous granulomatosa or a neoplasm. I promptly remove this lesion and submit it to the pathologist. Before we get to the diagnosis, let's go back and talk about a couple things. Here's the original radiograph. There is some denser bone in the left mandible, but it's very subtle and diffuse. This truly doesn't look concerning, more like a variation of normal anatomy. When I looked at the immediate post-operative radiograph, one subtle finding immediately caught my eye. Right here, the widening of the periodontal ligament. Normally, the periodontal ligament space appears as a thin, uniform line around the root of a tooth. This is a very subtle but a very alarming radiographic finding. This tiny detail is easy to overlook, but it can be one of the earliest signs of cancer. The other big red flag was the decreased sensation of his lip and chin with no known cause. I spoke with the pathologist multiple times, and ultimately the tissue had to be sent to a specialty lab in Texas for staining. When the final diagnosis came back, it confirmed our worst fear. This was an osteosarcoma of the mandible. Osteosarcoma of the jaw is extremely rare, presenting in less than 1 person per 1 million people. It's also notoriously difficult to diagnose. In one study of 20 patients with osteosarcoma of the jaw, 15 experienced a significant delay in diagnosis due to missed radiographic findings or incorrect pathology. The treatment requires removing the tumor with wide margins, and in a case like this, that means portions of the mandible and the overlying skin. This is an enormous procedure which takes place in a head and neck oncology institution. He had seen multiple doctors before me, so getting him as quickly as possible to the head and neck oncology team is essential. This case is an extremely rare diagnosis, and there's a good chance I'll go the rest of my career without ever seeing an osteosarcoma of the jaw again. I am amazed at how fast this cancer went from subclinical to a large exophytic mass. It was less than a week. The key takeaway from this case is to trust your instinct. The biggest red flag here with this patient's presentation was the numbness of the lip and chin. This symptom can have many causes, but malignancy must always be considered. Diagnosing something like this in a 17-year-old is devastating for the patient and the family. We are all hoping and praying for the best outcome as he begins his treatments. Cases like this are a reminder of how important it is to be hypervigilant on patients with concerning clinical findings. The smallest radiographic detail can make the biggest difference in a patient's life. I'm Dr. Tom Bolten. Thank you for watching this tough episode of the Open Reduction.